Good afternoon. My name is Jane Barrett from the International Federation on Aging. It is a great pleasure for the IFA to be hosting this important webinar addressing barriers to adult vaccination. Adult vaccination is a vital contributor to healthy aging, without which many adults, especially those with chronic comorbidities, could see marked decline in functioning from vaccine-preventable diseases such as influenza, pneumonia and shingles. We are very pleased and very proud to have with us today, one of the leaders not only in Canada, but in the world with respect to this particular field, Dr. Allison McGeer. Allison trained in internal medicine and infectious diseases at the University of Toronto and then completed a fellowship in hospital epidemiology at Yale New Haven Hospital. She was a microbiologist and the director of infection control for Sinai Health System from 1990 until 2019. And she's currently a clinical scientist at the Lunenfeld Tannenbaum Research Institute of Sinai Health System and a professor in the Department of Laboratory Medicine and Pathobiology and the Dalla Lana School of Public Health at the University of Toronto. She has been a member of the Canadian National Advisory Committee on Immunization, and she has both a research and a personal interest in improving adult vaccination. And just before we got on the line, Allison told both Paula and I that she has challenges with technology like I do, but we've made it, Allison. So I hand the floor over to you and thank you very much for being with us today.
It's a pleasure, Jane. Thank you for having me, and thank you to everybody who's on the line. Normally, I start at the beginning of presentations and say, you can stop me at any time and ask questions, and I will say that now. I think that the control room may have to interrupt when that happens because I'm not sure I can follow slides and chat at the same time. Please do send, if you have a question about a particular slide or thing I'm talking about and want to ask it, please do send that in and we will try to accommodate it. But there will be lots of time for discussion at the end. I've been asked this morning to talk about how we might start addressing the barriers to adult vaccination, and this will very much be a Canadian perspective. There are non-Canadians on the line. In fact, it's probably going to be a bit of an Ontario perspective because if you're a Canadian, you'll recognize that in Canada, health, including public health, is a provincial responsibility. And so although there are some things about our vaccination systems that are national, many of them are provincial and sometimes quite specific. So let's move on. There are now, I think, a number of different frameworks for thinking about what makes for an effective vaccination program, and this list in front of you is the way I've currently been thinking about it. I think fairly similar to others. All of these components are necessary. Any one of them is not sufficient, and what kind of mix you have or what kind of mix you need is variable over time in different jurisdictions and about vaccines. So item number one is evidence of and belief in the importance of the burden of disease. Obviously, you have to have an effective vaccine, but you also have to have people believe in the effectiveness of vaccine. There needs to be advocacy from many different directions for successful vaccination programs. You need to have an effective delivery system, and then at the end, you need to have some way of measuring how well your delivery system is working and some sense of accountability about improving the vaccination program if you need. So let's now go into some of these things specific to adult vaccination programs. So obviously, if public health is recommending vaccination programs, there is sufficient evidence of burden of disease from their perspective to warrant vaccination. And my apologies for... Sorry, is that back now? You okay? I think the challenge in thinking about burden of disease and being able to express it and describe it for many adult vaccines is that the etiology is difficult to diagnose. And so we can say confidently that there's a big enough burden of pneumococcal pneumonia to warrant vaccines against pneumococcal pneumonia, but it's actually quite hard to tease out what the etiology of that shadow you see on the chest x-ray, because accessing lungs is difficult. And so we do have a challenge with describing burden of disease for pneumonia, for influenza, for pertussis in adults. Nonetheless, I think we would all agree that we can get good evidence of burden, and for those vaccines that are recommended, we have good evidence of burden. Similarly, there's lots of challenges with interpreting the evidence of vaccine effectiveness for the vaccines we use for adults, and this is an important difference between vaccines for adults and vaccines for kids. Still, there's good evidence. However, you know, many of the vaccines that we recommend for adults are vaccines where there's a lot of room to argue about how you interpret the prevention of specific versus non-specific outcomes. So for influenza, is it important that we prevent influenza infection, or is it important that we prevent influenza-like illness? So when people are really sick with fever and cough, or what do we just want to prevent hospitalization really? Similarly, when we talk about pneumococcal pneumonia, are we content talking about the prevention of pneumococcal pneumonia? We need to talk about pneumonia, and this gets down to the individual level. You know, people who get their flu vaccine often want to be protected against all influenza-like illness, and you hear very frequently, I got the flu even though I had my flu vaccine, and you might know that it's not influenza they had, but it's still it still makes it hard to assess evidence individually. We have other difficulties with interpreting evidence in adult vaccines, and influenza vaccine, of course, is a major problem because there's so much variability from year to year. But there are also some other important things that distinguish adult vaccination from children's vaccination. Most of the vaccines that we give to children, we want them to have protection for 4 or 5 years when their risk is high enough. So measles, mumps, a pneumococcal vaccine, those are all vaccines where we want a lifetime of protection, but we'll be very happy with protection of small children in the 4 or 5 years when they're at highest risk. Whereas if I'm giving HPV vaccine to a 15-year-old, I want to know that that 15-year-old is going to be protected for the duration of her sexually active years, which could be 60 years. So when you deal with adult immunization, you have to be able to cope with the fact that when you start a vaccination program, you don't know how long the duration of protection with new vaccines is, and that's much more difficult for adult immunization than for pediatric immunization. So there are some evidence challenges specific to adult immunization programs, but again, if we've made a decision that we're recommending vaccines and we're really talking about successful vaccination programs, we're talking about those programs for vaccines where we have sufficient evidence and we're happy that the evidence is there. So then we move on to, if I could make my slides move. um, where the rubber hits the road. So this slide is a table of how well we're doing with adult vaccination programs in Canada for vaccines that are recommended by our National Advisory Committee for Immunization. So there is no question here that there is good evidence of burden of disease and good evidence of effectiveness, such that our public health departments recommend vaccination. And if I put this slide up with pediatric vaccination programs, you would see that every number was in the 80s and 90s. But for adult vaccinations, we're really not doing well. We're not doing badly in influenza vaccine for older adults. When I put this slide up for healthcare workers, right, this is a C+, and then a whole lot of Fs. And so then the question becomes, okay, if the science is behind these, what are our barriers to delivery and how do we get past them? So first of all, let's talk about burden of disease. And particularly for influenza and pneumococcus, we have a really significant problem that these diseases are not scary to us. And this is straight human psychology, okay? Things that are frightening in life are things that are new, unusual, foreign, rare, and have a high case fatality. So everybody is scared of meningitis. And the reason we're scared of meningitis is because if you get it, it can be a devastating disease, okay? A significant risk of dying. 1 in every 8 people who gets meningococcal meningitis dies from it. And if you don't die from it, there's a lot of very severe consequences. So that, to all of us, is a scary disease. Influenza, in contrast, is a disease that we all know, okay? We've all had influenza-like illness. You get it, you get sick for a couple of days, you get better from it. It doesn't feel scary. It doesn't feel like there's a significant burden associated with it. The problem is, for both influenza and pneumococcal disease, even though they don't feel scary, they occur so commonly that many more people die. So you see in this little box, these are numbers for Canada overall. So in Canada, about 15 people die a year of meningococcal meningitis. About 2,500 people die of influenza. But our psychology is such that when you offer people vaccines against meningococcal meningitis, generally speaking, not hard to get people to get those vaccines. Offer people vaccines against influenza, it's too ordinary, it doesn't feel severe, shouldn't be a problem. So one of our problems with adult immunization is in trying to get people to accept the fact that these diseases that don't feel scary are actually dangerous. The second thing that is a challenge with belief in burden of disease for adult immunization is that it's much easier to believe in things we can identify. So people are, I think, are much more willing to take shingles vaccine than they are to take flu vaccine and pneumococcal vaccine. And that's because even though shingles vaccine very rarely kills people, it's common enough that everybody knows how awful it is or how awful it can be when somebody gets shingles. And so when you can see the disease and you can recognize it, something that you can know you want to prevent. Influenza, of course, and pneumococcal disease these are pathogens that give you pneumonia or other non-specific illnesses. And so even healthcare providers have trouble saying, well, if I can prevent influenza, I'm preventing this proportion of pneumonia. If I can prevent pneumococcal disease, I'm preventing this proportion of pneumonia. If you can't see the things you're preventing, makes it much harder to believe in burden of disease. So we really do have some challenges with adult immunization in getting all of us, just regular healthcare providers, and the rest of the population, to believe in the burden of disease associated with these specific pathogens because of their very ordinariness and the fact that they don't stand out, people don't have a label. Good news from this perspective, I think, is that at least for us healthcare providers, now that we have better tests for influenza and we're recognizing transmission in hospitals are probably doing a lot more testing. And so I think healthcare providers are starting to recognize that influenza is much more severe than we thought it was before we could do testing for it routinely. And so I think some of that is changing, but this is an ongoing real challenge with us just being able to incorporate into our belief systems the need to prevent these diseases. Okay. Vaccine effectiveness beliefs are a challenge for a different reason. And I think the biggest gap between evidence and belief in vaccine effectiveness is, at least in Canada, what is a deeply embedded belief that vaccines need to be 100% effective to be worth giving. And I'm willing to bet that everybody who's listening has had somebody say to them, influenza vaccine or pneumococcal vaccine doesn't work well enough for it to be worth me getting vaccinated or for it to be worth me recommending vaccines to my patients. A really, really common sensation. This, of course, it's really silly, right? It's not about does it work 100% of the time? It's really about, is the benefit from the vaccine greater than the risk of the vaccine? And what's even more striking is that this is vaccine specific. Okay, when I have my hat on as a vaccinator, people only want me to give them things that work all the time. When I have my hat on as a regular physician where I'm prescribing medications, nobody expects them to work 100% of the time. So this is just the examples on these slides, a bunch of preventive things we do with medication that we do for very good reason and how successful they are. So we strongly recommend statins for prevention in people who have a history of coronary artery disease. They prevent your risk of heart attack by about 28%. We would all recommend blood pressure screening and putting people with high blood pressure on medications. They reduce your risk of heart attack by 20-25% and stroke by 35 to 40%. So we have this double standard in vaccines versus medications that we need to get past in order to get people to believe in and use adult vaccines. The sense, at least in Canada, that a vaccine has to be very effective to be worth having is driven substantially by our pediatric vaccines, which are mostly very successful, but it's still it's still critically important that we can move past this sense of the requirement for vaccine efficacy if we're going to expect to do well. And I think we've figured that out now, but it really means that we need to focus going forward on reframing in communication and education and being really clear that our requirements for a vaccine are not that it works all the time, but that it works enough of the time to provide a significant benefit. And I think you'll start to hear that now in public health communication and in how adult immunization is taught to people, so that we can try to absorb that and make that change. Okay, so now let's move on to the need for advocacy. Need for advocacy is important for all prevention programs, and that's a function of the fact that prevention is always a hard sell. If you have an opportunity, Harvey Feinberg, who used to be the director of public health at Harvard University and then was the executive director of the U.S. Institute of Medicine for a long time, if you Google him, you will get one of his articles or one of his presentations on why prevention is a hard sell, talking about all of the reasons and what we might do about it. But really fundamentally, when you're preventing things, your outcome is nothing, right? And in my role in infection control at Sinai, my very best days are something when nothing happens. And that's hard. It's hard to appreciate when that happens. We have this recurring problem with all sorts of public health programs where things are going really well, and somebody says, well, why are we spending all this money on people maintaining, the TB program in New York City was one of the is one of the most famous. Why are we spending all this money on all the money on the TB program? They had this huge outbreak because, of course, the reason they didn't have a problem was because all those people were working. But when you work to not have a problem, you can't see it. It's not dramatic. You're not rescuing children trapped in wells or doing liver transplants or seeing things where success is immediately visible, can be dramatic. It's not personal. You can't see the people who you have protected, right? If you treat a child with meningitis and the child gets better, that's visible success and personal success. You can tell the story. When you give a child a vaccine and they don't get meningitis, you don't know which child was going to get meningitis, no story to go with. And then, of course, the rewards are delayed. Then you give a vaccine, you're protecting people for the future, but not for now. If a government introduces a vaccination program, the benefits are going to accrue to the next government, not this government. And finally, for all healthcare providers, we would prefer to make sins of omission rather than commission. So if I give somebody a vaccine and they have a vaccine adverse event, I feel awful. If I fail to give somebody a vaccine and they subsequently die from influenza, that's just not as bad. Okay, and that's psychology again about doing things, right? Because either way, there's a bad outcome. And the evidence is very clear that fewer of my patients will have a bad outcome if I give them influenza vaccine than if I don't. But it's not how it feels instinctively. And so always it's hard to pitch prevention. And because of that, it is essential, if you want to run good prevention programs, that you have people who are strong, who are vocal, and who are persistent about prevention. And who those are can be highly variable. So in Canada, in the pediatric vaccination programs, pediatricians have been this enormously powerful voice for children across Canada for many, many years. In the US currently, the US Centers for Disease Control is a really vocal, solid, persistent advocate for vaccination programs. To the extent that they actually are, I think, annoying a bunch of people now because they're pushing so hard on so many vaccination programs. I think Public Health England is another example of people with very strong voices to keep vaccination programs on the front burner, to make sure they get funded, always to be doing the best you can. And one of our challenges, I think, is that we don't have that advocacy, at least in Canada, for adult vaccination. And I think that's because maybe we expect adults to behave rationally, and we kind of think if the evidence is there and the vaccines are available, then people will just do the right thing, and we forget that, things change, people don't hear about vaccines, and that people reliably don't invest enough in prevention. So if we want to have successful adult vaccination programs, we really need to work at both a global and a local level about trying to build the advocacy that is needed to move vaccines forward. Okay. Then you need an effective delivery system. And by delivery system, I'm starting from when it leaves the manufacturing plant until it's in the arm of an individual who's getting it. And I can remember my first meeting of the National Advisory Committee on Immunization, when people were talking about the vaccine schedule for a new pediatric vaccine, and I couldn't understand why the conversation went on for so long about exactly where that vaccine should fit in the schedule. But I've got it now because we don't have it for adults. An effective delivery system has to be really simple. It has to be perfectly clear. It has to be absolutely reliable. It has to work all of the time. It has to be stable over time so that people know things and they don't change, or they change a minimal amount so that everybody can understand how it's going to work. And then it has to also use minimal resources. That's time, money, and thoughts. Sorry about that typo. From everybody in it, from the people who deliver the vaccine to the healthcare providers, to the people who are getting vaccinated. Everything that makes delivering that vaccine just a little more difficult or complicated is going to interfere with delivery. And so we tend not to think about this. Okay, we have a very successful pediatric vaccination program across Canada. Okay, this is the Ontario pediatric schedule. Okay, now when I look at this, okay, the timing of vaccines has not changed from sometime before my kids, okay, who are now in their late 20s, okay, got their vaccine. So vaccination in Ontario doesn't look like vaccination in other places necessarily, but our vaccination schedule is 2, 4, 6, 12. The 15 was new with varicella vaccine, and 18, and then 4 to 6 years. And that, we have not changed that in probably about 50 years. And every time we introduce a new vaccine, we make it fit, and we think very carefully about how to make sure that you're not giving more than 2 needles at each visit, and how to make sure you're getting the best bang for your buck, and how to make sure that it's easy and simple for people to do it. And the result of that is we have this system that looks easy, that everybody knows, that is simple to follow for everybody, and works not perfectly, but very well. And it needs continued work. And one of our challenges in Ontario now, for instance, is that many people don't have family physicians anymore. So this was a role of family physicians or pediatricians. When people don't have their family doctors reliably, then you have to have some kind of backup system. So it's not only that this took a long time to build, it's also that it needs to be actively and very carefully maintained, and we do a great job. Let me give you just a couple of examples of how badly we do this for adult vaccines. So, adult vaccination for zoster vaccine in Canada, there's 2 vaccines available now, and PHAC abbreviates them as RZV for recombinant zoster vaccine. That's the non-live preparation that requires 2 doses. And then LZV, which is live zoster vaccine, which is the older vaccine, been around for longer. That's a live attenuated vaccine. So the first thing is that the Canadian recommendation is that adults aged 50 years and over receive the recombinant zoster vaccine. And in addition, you might consider zoster vaccine for immunocompromised adults who are older based on a case-by-case assessment of the benefits and risks. In a pediatric vaccination program, we would never permit that kind of waffling, because that kind of waffling makes delivery more complex, it makes it more difficult, downloads the decision-making to people who don't have as much vaccine experience as Nancy does, okay, and means that people just don't know what to do, and when you don't know what to do, tend not to vaccinate people. So that's bad enough. But then we move to Ontario, and in Ontario, the other vaccine, the live zoster virus vaccine, is recommended for adults over the age of 65. So now we have an age discrepancy between what the Canadian recommendation is from Nancy and what the Ontario recommendation is. And we provide it for adults who are 65 to 70 in family physician offices. So if you're over 70, it's recommended in Ontario, but not paid for. You have to get a script, you have to go to your pharmacy, you have to pick it up, you have to get back to the office, you have to book a second appointment in the office with your doctor to actually give you the vaccine. You have to figure out whether or not you have an insurance plan that covers it. If you're 50, Canada says you should get it, but Ontario says you don't need it. So now, none of this appears to be fatal in terms of recommendations, but it's not the kind of thing that we can actually tolerate if we want to reliably get vaccines into people's arms all the time. Okay. Similar example with influenza vaccine and adults in Ontario. Since 2012, pharmacies have been permitted to give influenza vaccine. They've taken over a substantial fraction, about a third, of influenza vaccination in Ontario. And I think, generally speaking, people regard it as a real benefit. It makes life easier for overburdened family physicians. It makes life easier for a lot of people who don't need to book a family physician visit now. They can just go to their pharmacy to get it. And last fall in Ontario, the government moved to recommending high-dose influenza vaccine for older adults. The problem associated with it was that pharmacies were not permitted to get supplies of high-dose vaccine. And, you know, it's hard to know why that happened. The decision wasn't made a long time in advance, and it's probably just a logistical issue related to people not being able to do it. But we had a bunch of older adults who are now getting their vaccines in the pharmacy. They've settled into a new habit. They know what they're doing. And suddenly we said, oh, geez, no, you have to go and see your family doc. And we've also gotten family physicians who've now sometimes gotten out of the business of routine vaccine clinics because they have a pharmacy that they share space with, and the pharmacy gives them vaccines and they don't need to do it. And suddenly they need to take it back on. Because only they can deliver high-dose vaccine. And that, again, it's a small logistical thing. You look at it and you think, oh, that's not a big deal. But when you sum it over all of the times that we do that, we just don't have a system that works to deliver it. So what do we need to create we're supposed to be talking solutions here, not problems. So what do we need to create an effective system? So the first thing that we really need to do in Canada, in my opinion, is to make sure that vaccines are paid for in the public health system. We've moved on to talking about pharmacare. If we're talking about pharmacare, we definitely need to be talking about paying for vaccines. And part of the reason for that is that at the moment, vaccines are not paid for in any of our regular healthcare budgets. Vaccines are in the public health budget. And that means that the introduction of adult vaccines has a significant impact on the total cost of vaccines and the total cost of our public health at a provincial level. Because remember that we desperately underfund public health at every level in the system, but then public health is also substantially a local responsibility. So the provincial budgets for public health are not that large, and adult vaccinations are then line items in this not very large budget, which makes the cost seem much greater than it actually is. And that, of course, means that it's hard to fund because you have the appearance of it being bigger than it is. So we feel like we can't afford new vaccines, whether they're for adults or kids, in Canada. In fact, our total vaccine budget, every vaccine is less than 2.5% of our drug budget, okay? It's what we spend on a single drug called Remicade, which is a good and very successful drug, okay? One drug is all of our vaccine budget. So we really need to figure out a way. First of all, we need to pay for vaccines for people so that they will get their vaccines. But we also need a system for paying for vaccines in Canada so that we stop not funding vaccines that clearly ought to be paid for because we have this artificial thing that makes them look more expensive. Now, when we do that, we're going to have to create guidance for decision-making with that, because one of the challenges of adult vaccines is that if I say, great, we've got a new inactivated vaccine that protects people really well against zoster, every adult over the age of 65 should get it, and the province will pay for it for every adult over 65 in the first year. That's a very expensive program. And then you settle down to people just get it when they turn 65. The way we've solved that problem for kids is we introduce programs and we introduce them into the birth cohort. So mostly when we introduce a vaccine in pediatrics, we don't have catch-up programs. And we need to decide as a society, as a province, how we're going to do those introductions for adults and what we're willing to pay for. We're also going to have to decide how to mesh Canadian recommendations and provincial recommendations for payment. So it's not a simple thing at any level to do this, but if we're going to have successful adult vaccination programs, we need to be able to get past these issues and make sure that all recommended vaccines are funded for adults. And then once they're paid for, then we need a system design for a system that's going to work. And that means, in my view, a careful and deliberate plan and resources assigned to it and an ongoing mechanism for making sure that as the system is built, it can be changed so that we can create a system for adult immunization that 60 years from now, somebody coming after me will say, this hasn't changed in 60 years. We have these set things, it's working really well. That's a lot of work to do, but the benefits in terms of improving protection of older adults are huge. We also need to start with both looking at what changes are already happening that we can take advantage of, and about thinking the full range of possibilities. So one of the really good things that's happened recently is that the Canadian Task Force on Preventive Healthcare has gone away from recommending annual physical exams to recommending periodic preventive health visits. And so if you think about that, that's now about saying different adults in different circumstances need health visits at different intervals, but we could actually build a system of preventive health visits. Now that we have computers, it's relatively easy to tell people and send people reminders about when their health visits are due, and then you can build vaccination into that life course program of preventive health visits. So there's some really good things that are happening that might help us. And of course we have, in Quebec, we have nurses who can recommend and give vaccines. We're using pharmacists to give vaccines. So there's, I think, lots of opportunity for looking at different scopes of practice and different arrangements for how we might better build a system for adult vaccines. But however we want to do it, I think we need to be making a conscious decision that we have to build an entire system. It's got to work for all of the vaccines, including the ones that are coming. And I think we know what the end requirements are, but it's going to take some really careful, thoughtful work and cooperation, collaboration in order to build that system. Okay, and lastly, you need to have assessment of performance and some form of accountability. There's, the old saw that you can't improve what you can't measure. And while that has some obvious faults, it is nonetheless true that if we don't know how well we're doing vaccination programs, we cannot improve them. And this is the slide you saw before, but with herpes zoster vaccine out of the bottom, we are getting better in Canada at looking at how well we're doing with influenza vaccine. The Public Health Agency of Canada now has an annual survey of influenza vaccines so we can track what's happening over time. But the numbers on this graph were pulled from many different places, and we really need to continue to work hard on figuring out how to have a adult vaccination scorecard, either provincially or nationally in Canada, so that we know where we are, and we can both see the need to improve and be able to track our improvement over time. And of course, then we get back to this issue of advocacy and accountability that we need at multiple places in the system to have people who feel it is their job to make sure that adult vaccination programs are well and effectively delivered, and we still don't have a really clear system for that. Our vaccination programs have been really clearly designed for pediatrics, and the people who work in those programs are busy doing pediatric programs. So we can't say to them, you know, and off the side of your desk, you need to worry about adult programs. Again, we get back to, we need to build into public health the system for both monitoring adult immunization and for being accountable for how good those immunization programs are. So, you know, all of this is big picture and long term. So just a minute at the end to talk about what can those of us who are healthcare providers do in the short term. And I think it's really important to remember that just because we can't get after the big stuff doesn't mean that we can't make a difference. And for individuals, that's about talking about vaccines, about being somebody who's an amplifier for public health messages about vaccines. One of the reasons that our pediatric programs work so well is because parents feel responsibility for their children. You want to make sure that their children are adequately protected and get their vaccines. So you can take that system and you can apply it to your parents, your husband, your siblings, right? And say, you know, you need, I guess I'm nagging you, but you should be talking to your family physician about getting the vaccines you need, to be looking for what vaccines you need. It's also important in this era of vocal anti-vaccine groups that that there are people who are reliably talking positively about vaccines. I think it's a general truth that that the voices of people who are in favor of things are quieter than people who are against them, and each of us has, I think, a responsibility to be part of the voice for vaccines, but it also makes a difference at an individual level to the people you're talking to. In healthcare providers, there are lots of things that healthcare providers can do, and this is a recent article in Vaccine using the World Health Organization evidence-based guide for what works, okay, and active recommendations of vaccine, reminders to people who haven't been vaccinated, evaluation of how well you're doing, feedback to healthcare workers are the four things that have been shown to increase immunization coverage. And then here on the last slide is a recent project from the Ottawa Family Health Team that was just published in the Immunize Canada Bulletin earlier this year about what they have been doing to improve their vaccination rates. So their nurses do medical record searches for people missing vaccination. They do notification of patients if they've missed vaccine or not been vaccinated. Those reminders are put in the charts so that when people come in for a visit for something else, the vaccine reminder is sitting there and can be used. They've started to review vaccination at every patient visit. They've started to stock some recommended vaccines that are not paid for in Ontario so that patients can purchase them and they don't have to go down to the drugstore with a script and bring it back. They provide lists of vaccines with Health Canada DIN numbers so that people can go back to their insurers and say, is this vaccine covered by my plan or not? They have an active promotion campaign where they have posters and pamphlets in the waiting room. They do social media posts. They organize their reminders for visits for HPV vaccine during Cervical Cancer Prevention Awareness Week. So they try to work together with other promotion campaigns. They have a medical director for patients with vaccine prescriptions so that if one of their patients gets a prescription for zoster vaccine and comes back, they don't have to have a physician visit. One of the nurses can just give it to them. And for vaccines like the zoster vaccine where you need 2 doses, you can pick up the 2 doses at your pharmacy and then they will store one of them for you in the vaccine fridge so that you can just come back for your second dose. You don't need a second script. So, you know, what you see here is, again, the pieces of a successful system. No miracles. There are no miracles in prevention. There are no miracles in vaccine programs, but every little piece you do helps, and you have to systematically go through and think of every small thing you can do. When you put them together, they've achieved really significant improvements in their vaccination rates in patients rostered with them. And so I think two messages out of this. Firstly, that as individuals with practices, all of us can make some difference. But the second thing is that you don't have to do everything, and you don't have to do everything at once. You start with one small thing and make that change, and then you think about another small thing and make that change. And over time, you build into your practice a system for much better delivery of vaccines without it taking you a huge amount of time or effort to build. So with that, I want to say thank you for your patience listening to me for all this time. And I think we can open it for questions now.
Okay, thank you very much, Alison. That was outstanding from our perspective and my perspective listening to it. So I'm going to kick off the questions. I want to take you back to the slide which talked about the vaccine, the group, and the percent vaccinated. And what struck me and of serious concern was the group 18 to 64 with a chronic condition, and 17% have had pneumonia vaccine. And it strikes me that, you know, people with chronic conditions such as diabetes or respiratory conditions or asthma, you know, are in a high risk category. You know, could you talk with us a little bit about that 17% and to what degree do we need to bring into this conversation patient associations?
So you know, the one of our challenges with vaccination programs is that we have so far really not done well with vaccination programs that target anything other than age. Now, the truth is, you're going to look at this slide and you're going to say, well, we haven't done well with programs that target age either, and you might be right. But I think the 17% for pneumonia vaccine is a double whammy. The first problem is that we have not persuaded physicians that the pneumonia vaccine is worthwhile. Okay, this is an interesting contrast to the United States, where for 65 plus the pneumonia vaccine rates are 65 or 70%. So it's really and very disappointing for me, because I always like to think that we do better with prevention in Canada than the Americans do. And pneumonia vaccine is a really glaring example of where we do worse, and that is about advocacy from respected people. A lot of that is I think about CDC work, but that's the first piece of the story. Okay, that even for over 65s, our delivery is only 37%. That's, you know, and that's bad. And then when you layer on top of it 18 to 64-year-olds, I think you run into two problems. The first problem is that at an identification perspective, right, that these patients, as you say, they go to their specialists. Specialists don't give vaccines, so they're not going to get in their specialist's office. When they're at their family physician, may not be for that particular problem. It's hard in your office, or I think it's easier now that we're moving to electronic medical records and you have more data in your office, but I think it's been hard to identify those people and make sure they get reminded about their vaccines. But there's also an issue, I think, for lots of 18 to 64-year-old adults. It's the issue that my mother had, and I try not to be anecdotal, but you know, I think this is a really powerful problem. If you have diabetes or COPD, it's tough enough to live with. If I then say to you, you are sick, I am giving you, one of the measures of that sickness is that you need a vaccine that other 35-year-olds don't need. That's just hard to swallow, you know? And so I think I think we somehow need a mechanism for trying to unbundle that if you get this vaccine, if you get this vaccine, you have been labeled as having a chronic illness.
Yeah.
And so I think you could do some of that in the way we communicate and the way we frame things. But I don't think, now, one of the possibilities, okay, that people have talked about, which sounds like a really cool thing to me to try, is that if we expand pharmacists delivering vaccines, then you could define people's underlying conditions frequently by what medication they're taking. And you could probably say that, if somebody's taking a statin, they probably have some underlying cardiac disease. They should get the pneumonia vaccine. And so you might set up a system where the pharmacist could make that recommendation and deliver the vaccine. Or the pharmacist could make that recommendation and then it could go back to the specialist. I think that has possibilities. I also think, interestingly, many obstetricians have been really good at recommending vaccine. It was a surprise to me because generally speaking, specialists have not been a voice for advocacy for vaccination in Canada. And certainly the obstetricians that I work with at Sinai, both for pertussis vaccine and flu vaccine, have been very strong advocates. They don't, however, see it as their job to deliver vaccines. So, I don't know. I'm not sure how we break that barrier because it's so clear that we see, on one side of the fence at my institution, I have a bunch of obstetricians who really see the need to protect their pregnant patients against pertussis and influenza and want their patients vaccinated. And the other side, I see pharmacists in the community and I think family practitioners who are just nervous about doing anything with pregnant women. Mm-hmm. And despite the recommendations, are really reluctant to vaccinate. And that's another problem we need to solve.
Just on that note, you did talk about, each of us can make that difference, can't we?
Yes.
And you start with a small thing, and I like the kind of scenario that this is a big system, and you can actually be part of this systemic change in what we do as individuals, whether it's civil society or whether it's an obstetrician or a patient. So we all have a role and responsibility. I just want to communicate from Sarah a question about vaccinations and are they publicly funded? And I know cost is a huge factor, as Sarah said. And, from province to province, the costs and the schedules change. So can you comment on that? Because I think that really is a barrier and sometimes almost a discrimination. That's my word, not anybody else's, but from one province to the next.
Yeah, it's, I think there's some good things about having a federation, because sometimes sometimes one province will make a decision ahead of other provinces and then we'll all get dragged into it. So I think sometimes it's actually might have accelerated vaccine introduction, but it does create, there's no question that it creates inequities that we don't want to have. Yes. I think a piece of our problem, the short answer, okay, so I think the short answer is that we're now having a serious conversation in Canada about pharmacare. If we can have a serious conversation about pharmacare, we, that is all of us as advocates, okay, your physician, your member of parliament, your associations, we all need to start saying, so even if we can't have national pharmacare or we can't have it for a while, surely to heaven, we can get back to a national immunization program. Mm-hmm. It's such a tiny piece of what we're talking about with pharmacare. So, just make you're not going to satisfy everybody with pharmacare for a long time, but you could do such a world of good by getting back to the national vaccination program. And I know that the national vaccination strategy got into trouble with HPV, and I hear the difficulties, but I am really hoping, looking at the discussion about national pharmacare, that we can leverage that to try to make sure that vaccines get in early and get done completely.
Because the way that IFA also sees vaccination is through the lens of healthy aging as part of a preventative action and a life course approach. You know, actually does talk about from babies to older age. And we also believe that if it was a robust conversation around pharmacare, that it would probably save many millions of dollars in the long run.
Oh, no question.
Look, as we wrap up, Dr. McGeer, I just want to give you an opportunity. You know, what would be the key messages that you would want the audience to take away?
So I think the first one is the one that you have pointed out, which is that at an individual level, each of us can make a difference. And just because it's going to take us a long time to get to the kind of really successful programs we want doesn't mean that we can't all be making a difference now. So that's the first message. And the second message is, at the same time, I think each of us should be asking what we can do to try to make sure that we can build a system. We've been talking about trying to build out immunization for, well, almost as long as I've been in practice, okay, which is a long time. And I think I really see now that we have enough successful vaccines and enough evidence about their benefit that we can start to build it, but it's still going to be a long haul. So the second thing that I would like people to do is to be asking themselves what they can do to try to support the build that we need for this much bigger program.
All right. Look, there is no words to really describe the presentation. It doesn't surprise me now that, you know, you are an admired speaker but a thoughtful leader in this whole area, because across this presentation you really demonstrated, you know, so many complex situations, but you've actually talked about it in a very simple way that, you know, the audience has been able to really appreciate. You know, some of the messages that I also can take away is that, you know, parents feel responsibility and apply it to their children, and perhaps we can feel responsibility and apply it to our older parents, friends and families. And I think that what you've given us today is a very insightful approach as to how we can, as individuals, but part of a bigger community and system, you know, support the ongoing conversation of adult vaccination as part of life course. So on behalf of all the delegates, attendees that are on this call, we really thank you for taking time out of your meeting to be with us today. Thank you very much, Dr. Allison McGeer.
Thank you. Take care. Bye-bye.
All right. Thank you very much. And to all of the attendees online, just to encourage you to be part of our ongoing webinars on adult vaccination and the conversation about a life course approach. And also just a teaser that the IFA will be having a vaccine summit on the 30th of October 2020 prior to our global conference in Niagara Falls. So thank you once again for being part of this important webinar, and feel free to contact the IFA for any comments or suggestions. I do see that we've got one or two questions that have come after the webinar, so we'll get back to you. But once again, thank you, and also to Paula Colosa, IFA, that has helped us with the technology today. Have a great day. Bye.